So, welcome everyone to today's lecture. Myself and Dr. Porter are going to be talking about the current landscape of pediatric epilepsy therapies today. My name is Dr. Katherine Xiong. I'm a clinical assistant professor and specialize in epilepsy over at Stanford Medicine Children's Health with an interest in genetic epilepsies. And then,
Hi, my name is Dr. Brenda Porter. I'm a pediatric epileptologist with a cold, so hopefully you can all hear me. And I specialize in a variety of different types of epilepsy, but today I'm going to focus on one of my interests, which is epilepsy surgery. We've divided this into two parts, so Dr. Xiong is going to start first. I will say that Dr. Xiong's middle name is Brenda, so there's Brenda times two today. And then I'll go at the end. The Q&A is open, so I'm going to try to pay attention while Dr. Xiong is talking and answer your questions. Already one question. Oh, somebody's wishing me well. And then Dr. Xiong will pay attention during my section, and we'll try to get your questions answered. So feel free to put them there. And then Dr. Xiong, please take it. Oh, we showed the CME slide. So you guys,
yep.
we'll show it again at the end if you need it.
Great. So to highlight, I have no disclosures. Dr. Porter receives funding, research funding from the MAH, FDA, TSC Alliance, and SK Life Sciences and Marinus, but none of these should be particularly relevant to today's discussion. So the learning objectives of today's lecture are going to be to review the current diagnostic approaches to patients with epilepsy, as well as some of our pharmacologic and dietary therapeutic approaches. And then Dr. Porter's section will focus on understanding the current surgical approaches to epilepsy, including focal ablation and resective approaches, and discussing novel neuromodulation approaches as well for refractory, generalized, and focal epilepsy management. So to start, I thought it'd be nice to get a shared understanding of how we think about epilepsy as a diagnosis at this time. So to open the day, I'd like to present a case. So this is a previously healthy 3-year-old patient who presents with a first-time seizure to your clinic. Imagine a family said she had an episode of tonic stiffening and loss of consciousness lasting about 3 minutes. And family asks you, does she have epilepsy? So if folks would like to and have the ability to, we'd encourage y'all to join our poll everywhere and just submit your responses of whether you think, yes, she has epilepsy with this first time seizure, no, or maybe. So I'll give folks a chance to get
Do you
it.
want to explain the pull everywhere thing in case they're not
Yep,
tech-savvy?
yeah, you can use either the QR code here to scan it and it will take you directly to the link, or you can text this code here, Katherine Xiong 265 to the number 22333, or join by web. All of these options should work. And so we're starting to get some responses. We'll give folks a couple of minutes to see. Right. So seeing a wide variety of responses, and I think in part this is because we probably need a little bit more information this time. All right. So the current, conceptual definition of epilepsy is really thought to be a disorder of the brain characterized by an enduring predisposition to generate epileptic seizures. But what does that mean for us as providers from a practical standpoint? Current consensus clinical definitions is described as follows, which is either that an individual has at least 2 unprovoked seizures occurring more than 24 hours apart. They have 1 unprovoked seizure and a probability of future seizures being similar to the general recurrence risk of after 2 unprovoked seizures, which is at least 60% in the next 10 years. And situations that would suggest a high recurrence risk would be things like having an EEG with epileptiform discharges, or imaging with, say, like a focal lesion on MRI that correlates with the seizure semiology and presentation. Or lastly, having a diagnosis of an epilepsy syndrome of something like childhood absence. So in this initial patient case, she's had a single first lifetime seizure. So with the information we have at hand right now, with no other diagnostic information available, We can't say that she definitely meets the criteria for epilepsy yet, but certainly could go on to if she had another event or further testing showed um, a higher future risk of recurrence. And so in this patient's case, 4 months later, you see them again in clinic. They've had a second tonic seizure event, so now would meet the diagnostic criteria for having epilepsy. Over the course of her clinical care with them, they go on to have new episodes of eye fluttering and behavioral arrest that appear consistent with absence seizures as well. And interestingly, also seem to develop a movement disorder over time with the head dystonia that seems to improve after eating. And so family, after meeting with you, especially after the second seizure, would like to know what comes next. You know, that you've given them a diagnosis of epilepsy. What did they take with that, and what are the next steps in their care? And so when we think about the diagnostic approach to epilepsy, I think it's critical to understand the sort of conceptual framework that we use in diagnostic framework as we think about our patients with epilepsy. And the first, layer of that really is going to be classifying and understanding the seizure types. Individuals can have focal onset, generalized onset, or unknown onset seizures. And how we further characterize them can go down to granular levels, including, specific qualities of the seizures. So, do they have specific motor activity with them or non-motor features? Do they have preserved awareness or impaired awareness during their seizures? And these pieces of information can be incredibly helpful for us as epileptologists when we think about where these seizures might be originating from. Could these seizures be related to specific types of epilepsy syndromes that can help us guide therapeutic decision making and prognostication as well? And so the second layer of this conceptual framework then extends into then epilepsy types. So similar to the seizure types, individuals can have a focal epilepsy, generalized epilepsy, combined generalized and focal epilepsy syndrome, or an unknown. And that's because, as we know, individuals with epilepsy can have multiple seizure semiologies and kind of multiple different types of seizures. So, for say someone with the diagnosis of a generalized epilepsy, we would may expect that a patient's EEG would show generalized spike wave activity, and they could have a range of generalized seizure types, including, say, someone with absence seizures, as well as generalized tonic-clonic seizures. Similarly, in focal epilepsies, patients can have both unifocal or multifocal disorders where seizures could arrive from a single or multiple locations within a given hemisphere. And their EEG similarly could show epileptiform discharges in just one region, like say the temporal lobe, or could arise from multiple regions in a hemisphere, like the temporal, parietal, and frontal lobe. And then we have combined generalized focal and generalized and focal epilepsies. And these are patients who have just that, both generalized seizures and focal seizures. And common examples of those would frequently occur in patients with, say, like Dravet syndrome or Lennox-Gastaut. And that leads us nicely into the final tier of this conceptual framework for epilepsy, which is the epilepsy syndromes. So an epilepsy syndrome refers to the cluster of features that incorporate seizure types, EEG features, and imaging characteristics that all tend to occur together. Um, Oftentimes, they are also specific age-dependent features, say like the age of onset of epilepsy, and may have unique specific triggers that come frequently in constellation. Patients may also have distinctive comorbidities like intellectual and psychiatric dysfunction as well as a part of this syndrome. And then the last component, which really is something we think about throughout the course of this framework, is going to be the etiology of a patient's epilepsy. And a patient's epilepsy could be classified into more than one etiologic category. For instance, in a patient with tuberous sclerosis, which is a specialty of Dr. Porter's, these patients are classified as having both a structural and genetic etiology. We know that this syndrome is due to genetic mutations in TSC1 or TSC2 genes that can lead to the overgrowth of tubers and infect the heart and kidney as well. And that can have critical implications in certain therapeutic choices, including the initiation of things like mTOR inhibitors for patients. Similarly, with regards to their epilepsy, the lesional or structural tubers in the brain play a huge role in the seizure onset for a lot of these patients, and can certainly play a significant role in the selection of additional therapeutic recommendations like epilepsy surgery for these patients. And so the structural and genetic etiology play a large role in both our sort of diagnostic classification of these patients, as well as in potentially our therapeutic choices for them as well. So, what tools can we use to help support us as we try to make the diagnosis of epilepsy for our patients, and also guide our therapeutic decision making? Probably the three most commonly used tools for us are going to be the electroencephalogram or EEG, neuroimaging modalities, and genetic and metabolic testing for our patients. I'd say probably all of our patients who get evaluated for a first-time seizure or a seizure-like event will undergo at least one EEG. Typically, these are conventional EEGs in which scalp electrodes are placed on the head surface, and they're brought in for a brief recording with or without video that lasts typically about 30 to 40 minutes, a routine study. In some cases, they may last longer, anywhere from 1 hour to even as long as 72 or even 5 days in the outpatient setting, and with some specific indications, but it's oftentimes an outpatient evaluation. Now, in some instances, EEGs may be completed in the inpatient setting. That can happen for things like emergencies when patients come in with, prolonged seizures like status epilepticus. Um, or in other cases, we may be intentionally bringing in a patient in for a prolonged EEG study if they're undergoing an evaluation, a surgical evaluation for management of refractory epilepsy. And so in those cases, patients may be in the hospital for as long as 2 weeks with the intention to have their seizures be captured while on EEG to better understand the seizure onset zone. And sometimes these EEG studies may actually include the placement of surgical placement of electrodes, either via stereotactic EEG, which is when electrode wires are surgically implanted into the brain areas of interest where we think seizures may be coming from, or via electrocartography, where electrode grids and strips, as demonstrated here, are placed over the brain surface directly under the skull. More recently, there's been the development of newer, less invasive modalities like high density or HD-EEG that have also been utilized for improved seizure localization. And these are scalp EEGs that have a higher density of electrodes than our conventional EEGs, where anywhere from 64 to as high as 256 electrodes are placed on the head surface. And this allows us to get better spatial resolution, and with the conjunction of new software analysis can allow us to localize potential epileptogenic cortex in a non-invasive manner. This technology is still sort of growing in its utilization in practice, so it's not yet widely available, but is something that I think has had increased development and interest, both from a research perspective as well as clinical applicability. Now, the next, I think, diagnostic tool that we utilize a lot for our patients is going to be neuroimaging. Um, I'd say a majority of our patients with epilepsy undergo some form of neuroimaging at some point over their clinical course. Probably a fair number of them undergo CT heads. While this is not the most ideal modality, given its limitations in soft tissue resolution, it's oftentimes something that's useful or used in acute settings in particular. Say with a first-time seizure presentation, as it allows for sort of more rapid identification of significant structural changes like hemorrhage, ischemia, or large mass effect like from a tumor, that are often important to rule out in that emergent setting. Now, the preferred modality that many of our patients who are undergoing evaluation for epilepsy is going to be the MRI. And this is recommended because it has far superior soft tissue resolution than, say, the CT. And typically for patients who are undergoing a formal evaluation for, say, epilepsy surgery, we typically would recommend that a high resolution, at least 3 Tesla scanner or higher, is used. And epilepsy specific protocols, so where specific imaging sequences are used, are recommended to allow for optimal sort of capture of the appropriate sequences to ensure the best structural identification with imaging. It's not uncommon that in many of our pediatric patients, we actually get repeat imaging. In many cases, patients oftentimes, if their first seizure happens when they're an infant, they may get an MRI at that time, and that's often before myelination is completed. So, in many cases, prior to myelination, we may miss some subtle structural changes, like, say, a focal cortical dysplasia, that may not be as oftenly sort of sequenced and apparent until myelination is complete. So some of our pediatric patients may undergo serial MRIs over time. This here is just a slide highlighting some of the imaging sequences that are recommended for epilepsy-specific imaging protocols. Now, the last sort of diagnostic testing modality I think we're using more and more for our patients with epilepsy is going to be genetic testing. Current guidelines from the National Society of Genetic Counselors, as well as the American Epilepsy Society that were released in 2023, recommend that all individuals with unexplained epilepsy be offered genetic testing. And this is because the identification of a genetic etiology may have significant clinical implications for our patients and go on to inform therapeutic selection, could influence our recommendations for epilepsy surgery for a patient, could help to facilitate the surveillance of known associated comorbid conditions for some patients, and may allow patients to be referred to participate in syndrome-specific trials. So what testing do we usually recommend for our patients? Current guidelines strongly recommend that comprehensive multi-gene testing with either an exome or genome sequencing or multi-gene panels be offered as first-tier testing. So those are highlighted here with the asterisks. The selection of the tests we recommend, though, we recognize may be based on a number of factors, including patient phenotype, but also availability of resources. So these tests can be expensive. So whether they're covered by insurance, whether it's feasible, out-of-pocket costs are feasible for families, all play a role in some of our recommendations as well. Probably the most frequently utilized testing modality at this point is going to be epilepsy gene panels. A genetic panel searches for pathogenic variants in a specific set of genes associated with a specific phenotype. So in this case, epilepsy. And most epilepsy gene panels that are currently commercially available include anywhere from 100 to 1,000 specific genes that are evaluated. The other most frequently used test is probably going to be whole exome sequencing. Now, as we may recall from our previous genetics experience, the exome comprises about 2% of the whole genome and contains the protein coding regions. And so with whole exome sequencing, not only are the variants, or regions associated with known epilepsy genes sequenced, but whole exome sequencing may also identify gene variants in regions that are not yet known to cause epilepsy. Whole genome sequencing is sometimes pursued in, say, a patient who you may suspect has a very high likelihood of having a genetic etiology, but in which whole exome or gene panel testing has come up inconclusive. And with whole genome sequencing, both the protein coding and non-coding regions are sequenced. And this is because we know errors in the non-coding regions can also cause clinical disease in very heterogeneous and complex ways. And so the examination of that is sometimes recommended in certain cases. Some patients may be recommended to pursue chromosomal microarray. With the chromosomal microarray, large multi-gene structural variations like chromosomal deletions, duplications, inversions, and translocations can be identified. And this should be strongly considered as a testing modality in patients with epilepsy who have concurrent intellectual disability, neurodevelopmental delay, autism, or multiple congenital anomalies. And then lastly, some of our patients may undergo karyotyping, which can be useful for the examination of things like ring chromosomes, as a ring chromosome 20 is a very well-known and well-described cause for distinctive epilepsy syndrome. The exact diagnostic yield really depends on the specific testing modality as well as characteristics of the population. But in general, we quote the yield being around 70% across all modalities. And as you can see here, the specific yield may vary depending on the specific modality. But we do know that diagnostic yield seems to be highest in our populations with epilepsy and concurrent intellectual disability or autism, or in our patients with severe developmental epileptic encephalopathies. So what diagnostic procedures did we pursue for our patient in this case? So shortly after her second seizure, she underwent routine EEG, which showed that she had rare 3 to 5 hertz generalized epileptic discharges, suggestive of possibly a generalized epilepsy syndrome. Her MRI brain was completed the following year and was normal. And much later in her clinical course, she eventually got genetic testing, which did demonstrate a likely pathogenic variant in the SLC2A1 gene, which we'll touch on later. So now that we've got, a sense of the diagnostic approach, how do we use this information to help guide our therapeutic selection for patients? Now, the aim of anti-seizure medication use is really to reduce the risk of further seizures. But how we go about selecting the medications for a patient can vary depending on a number of factors, including the specific seizure type or epilepsy syndrome, the age of the patient, sex, specific comorbidities, or interactions with concurrent medications, and the cost to families. One, I guess, framework to think about therapeutic selection is, selection based on seizure type. As we know, different anti-seizure medications can be suitable for different seizure types. Um, broadly speaking, probably the agents with utility for generalized seizures is our most limited selection. Listed here are probably the most common agents that we'll initiate for patients with generalized epilepsies. You've seen probably some of your own patients on Keppra or valproic acid, lamotrigine, et cetera. I'd like to point out for ethosuximide that it's a great agent for generalized absence seizures, but unfortunately is not as efficacious for the other generalized seizure types like myoclonic, generalized tonic-clonic, etc. Now, we have some medication options that have efficacy for both focal and generalized seizures, but may be more efficacious for focal onset seizures. Those are medicines like phenytoin, phenobarbital, perampanel, carbamazepine, etc., where they can be applied for generalized seizures, but we tend to think of them as being better focal agents, but may be used in some cases. And then lastly, there are some medications where we really think of as being most optimal for focal onset seizures. These include a lot of medications that have a mechanism of sodium channel blockade, like oxcarbazepine or escarbazepine. And in some instances may actually exacerbate generalized seizures for some patients when used. Things like we know sodium channel blockers can actually worsen myoclonic seizures in patients with, say, JME, juvenile myoclonic epilepsy. So this is one sort of therapeutic approach to help guide selection based on seizure type. Another approach that I think, or framework for seizure treatment that we're using more and more often is syndrome-specific treatment approaches. And in part, I think this is an approach that's used widely in pediatrics and in pediatric neurology because a majority of our epilepsy syndromes actually present in the early life and childhood period. So I think that probably is a reason we use this sort of framework more frequently than, say, our colleagues on the adult side. And we also know that several of the early life epilepsy syndromes oftentimes have patients who have multiple seizure types of various semiologies and quite commonly could have a combined focal and generalized epilepsy type, which may make selection of medications based solely on seizure type a little bit more complicated. And I think lastly, this syndrome specific framework has become, I think, increasingly more utilized in part as we've had improved characterization of our epilepsy syndromes and currently improved sort of understanding of the pathophysiology behind some of our syndromes as well. That has really led to increasing sort of consensus guidelines being formed to help guide therapeutic selection. I think one classic example of this is infantile spasms. As we know, there's a very commonly seen epilepsy syndrome in our patients where young infants, anywhere from, like 4 to 18 months, come in with these clinical flexor spasm events, have this very abnormal EEG background shown here called hypsarrhythmia. And the therapeutic selection and agents that we use are very different than any of those that were listed in the previous slide. And it's very uniquely specific to this epilepsy syndrome. So first-line therapeutic treatment for infantile spasms is actually ACTH or high-dose corticosteroids. And newer evidence has come to suggest that early initiation and utilization of vigabatrin for potentially all patients with infantile spasms may be indicated and have better outcomes as well. And so, this is a nice example of the syndrome-specific sort of therapeutic approach that we're starting to utilize for our patients more and more. One syndrome I wanted to highlight, in part because there's been a lot of new therapeutic developments in the last few years for this, is Dravet syndrome. And so Dravet syndrome is one of our more common genetic epileptic encephalopathies. It's an infantile onset developmental epileptic encephalopathy that is largely due to pathogenic variants in the SCN1A gene that results in dysfunction of the alpha-1 subunit of the sodium channel. And these patients have an incredibly refractory and severe epilepsy syndrome where they can have very prolonged hemiclonic seizures or focal and generalized status epilepticus with seizures that can last hours. And they can have multiple different seizure semiologies of various types, including myoclonic, focal absence or focal impaired awareness seizures, etonic and tonic seizures. And their seizures are known to be incredibly drug resistant and concurrently also have comorbidities, including intellectual disability, behavior concerns, and sleep disorders. And since 2018, we've actually seen 3 new drugs be approved specifically for the use in Dravet syndrome, with cannabidiol and serapental being approved in 2018 and fenfluramine approved in 2020. Cannabidiol, also known as Epidiolex, is the brand name, is a highly purified form of CBD that conveniently has very minimal THC, which we know can be seizure provoking, and has been shown to be very effective in helping to reduce the seizure frequency in these patients with Dravet. Similarly, serapental is a newer medication that was recently developed that has works by modulating the GABA A inhibitory receptors and also has a synergistic effect in inhibiting one of the CYP enzymes that can actually help to increase the serum concentrations of a medication called clobazam or Onfi that many of these patients are on. And we've seen that with patients with Dravet who get started on serapental, they've had up to as high as a 70% responder rate in these patients, which is quite impressive given that these patients have generally been refractory to so many other medications. And then lastly, the newest medication that we've been using for these patients is fenfluramine. This medication is actually quite old. It was popular in the 80s and 90s as an appetite suppressor, but was banned in the 90s given some of the side effects of cardiac valvular heart disease. But they incidentally noticed at that time that patients with epilepsy had significant reduction in their seizures. And later on in the late 2000, recent 2020 was sort of reevaluated as an anti-epileptic and has been shown to be incredibly effective for our patients and works by increasing serotonin and activating serotonin receptors, which is a unique mechanism of action that many medications prior to this hadn't really been utilizing. And so nowadays we actually have, consensus guidelines that have recommendations for treatment algorithms for patients with Dravet syndrome. And these consensus guidelines can be really useful for our patients in not only sort of improving the quality of care, right, and standards of care for this patient, but can hopefully help to achieve improved outcomes for them in general, and allow for hopefully better sort of seizure control in the long term. So in these last few moments, I'd like to touch on some of the newer medications we're excited to see on the horizon from a pharmacologic standpoint, and then I'll touch briefly on some dietary therapies that we use as well. So one of the medications that we're excited to see coming into the pediatric epilepsy treatment space is cenobamate. This is a recently approved anti-seizure medication that's used in adults for the treatment of focal epilepsy. And it works by promoting the inactivation of sodium channels, as well as by modulation of some of the GABA A inhibitory receptors. And it's been found to be very effective in the adult population. And so there's now currently a phase 3 open label study that's ongoing for pediatric patients and is enrolling patients as young as 2 years old to see if this will be an effective and safe option in the pediatric population. But off-label use has already been relatively widely applied with very positive responses in case series and case reports in the pediatric population. for focal seizures. And additionally, while it's really being studied as a focal anti-seizure medication option, there's been some early anecdotal evidence and limited case series that seem to suggest that there may be additional efficacy for the treatment of generalized seizures or combined focal and generalized epilepsies as well in patients with epileptic encephalopathies like LGS. So I think it's really exciting to see new medications coming on board for our patients that seem to be really effective. Another mechanism of action that's being explored for therapeutics is neuroactive steroids. So ganaxolone is a recently approved medication for the treatment of CDKL5 deficiency disorder. It works, it's a synthetic analog of allopregnanolone that targets the GABA A inhibitory receptors. And has shown to be effective for the specific syndrome of CDKL5, but there's ongoing work to see if it would be similarly useful for other syndromes like LGS, TSC, and PCDH19. As I mentioned with fenfluramine, I think one of the new therapeutic targets that's getting a lot of interest is in serotonin and serotonergic therapies. So in addition to the recently approved fenfluramine, there's ongoing phase 3 trials for a new serotonin 2C receptor agonist that have shown some very promising early results for the treatment of seizures in patients with developmental epileptic encephalopathies like Dravet or LGS. And so we're really excited to see so many new therapeutics on board. And lastly, I just wanted to mention too that, there's been so much movement in the genetic identification of genetic etiologies for patients with epilepsy. And I think this is really going to open the landscape up to disease-specific genetic therapies really being a frontier in therapeutic treatment options for our patients. Where we've seen probably the most growth so far is in treatments for Dravet syndrome right now, as it is one of the more common single gene causes for epilepsy. And there are currently 2 gene therapies that are in trial at this time, including ETX-101, which is an AAV vector delivered transcription factor, and then STK-001, which is a antisense oligonucleotide. And so I think these are going to be spaces that we see a lot of growth and development, particularly as we get more and more patients identified with specific genetic etiologies. All right. In these last few moments, I'll talk about dietary therapies. So, certainly the first line for most of our patients is going to be pharmacologic agents for treatment of their seizures. But in some instances, we will start to explore and consider dietary therapies for patients. There's currently 4 different ketogenic diet therapies that are used by patients. And the fundamental component of each diet really is this ketogenic ratio, the relative ratio of the amount of fat to the total number of protein and carbohydrates in the diet. And all of these ratios have a high fat to low protein carb ratio, but each of the 4 diets can vary in the specific ratio as well as sources of, say, fat and carbohydrates. So the 4 diet therapies that are used at this time are listed here. We've got the classic ketogenic diet, medium chain triglyceride diet, modified Atkins diet, and low glycemic index treatment. And this graphic really highlights how they vary from one another. So the ketogenic diet, the classic ketogenic diet, is the diet that's most frequently used, I think, in our pediatric population. In this case, the fat source in the diet comes from long-chain triglycerides. And as you can see in the image, the ratio is the most restrictive, where patients have typically 90% of their calories are rising from fat. And the goal is to achieve as close to a 4-to-1 ratio as possible. In some instances, patients may use a medium chain triglyceride diet, and it differs from the classic diet based on the fat source. So the primary fat source in this case is medium chain triglycerides. The advantage of that is that MCT oils actually yield more ketones per kilocalorie of energy, which essentially means that less fat is required in the diet and can allow for some liberalization in the amount of carbohydrates and protein in a patient's diet. So it could be easier in that way for some families. The challenging part of this diet, though, is that MCT oil as a fat source is not as well tolerated from a GI perspective for a lot of our patients, which may limit its sort of wider applicability. The modified Atkins diet here in the bottom left is probably the most frequently used diet in the adult population. And I think that's in large part because it is one of the more liberalized iterations of the ketogenic diet. It still is a high fat, low carb diet. And in this case, there's a very rigid carbohydrate restriction of somewhere between 10 to 20 grams a day. But it otherwise allows for some liberalization in the amount of proteins the patients are allowed to eat, as well as the total number of calories, which is a lot easier for particularly our adult patients who say are responsible for their own diets to maintain and to acclimate to. And the last diet here is the low glycemic index treatment. In this diet, the principle is really that the goal is to minimize the sudden increases in changes in blood glucose, which have been shown to be can particularly sort of decrease the benefits of the ketotic state. And so in low glycemic index treatment, the amount of carbohydrates is a bit more liberalized. Patients can get up to 40 to 60 grams a day, but the source of the carbs is really controlled, and so they all need to come from low glycemic index sources to prevent significant fluctuations in the blood glucose. So how efficient or sort of effective is the ketogenic diet? It generally, we say about 50% of our patients will have a more than 50% reduction in their overall seizure burden. So this is a palliative therapy. It's not expected to be curative, but it can be really effective in minimizing the overall seizure frequency for some of our patients. And about 1/3 of the patients will have a greater than 90% seizure reduction. So that can be significant. And we do see that similar rates of efficacy are noted across the different diet types. But it does require guidance by a trained dietitian and physician, as well as frequent monitoring with the initiation. How the ketogenic diet works is still something that is a growing area of study. We know that the ketone bodies themselves have anti-epileptic effects, but there's clear evidence now that the diet efficacy extends beyond the ketones themselves, and that the diet creates states that can affect the gut microbiome, the neuroendocrine system, and even affect things on an epigenetic level that all seem to play a role in its anti-seizure effects. So who gets the diet? Typically, we say that dietary therapy should be considered in any cases of refractory epilepsy, so patients who have required more than 2 medications and still continue to have seizures. There are certain populations where the diet is strongly considered very early on. In fact, the 2 syndromes listed here, GLUT1 deficiency syndrome and pyruvate dehydrogenase syndrome, the ketogenic diet is actually first-line therapy for these syndromes, but we may think about it earlier on in some of these syndromes as well. And similarly, there are specific patient populations where the diet is strongly recommended to be avoided. And that specifically is patients with fatty oxidation disorders, as it can lead to metabolic crises. The diet isn't for everyone, and that's in large part because it's a big undertaking for our patients and our families. And so a big part of sort of the screening of that is the evaluation and the counseling. And so, not only are we evaluating for labs, but we're oftentimes just trying to get a sense of, is this feasible for this patient and this family? As there's a lot of needs for meal prep, there can be huge psychosocial impacts for the patient and the families. And there may be specific behavioral traits, like say individuals who may have already very restricted dietary preferences at baseline that make them suboptimal candidates for the diet. And, we have to set clear expectations for families that in many cases, this is a palliative treatment option. It's not a curative one. And so we want to make sure families understand that going in. So what therapeutic selections did we end up making for the patient in the case 1? So prior to her coming to me, family had been started on Keppra and later valproic acid for the treatment of her tonic seizures and absence seizures. The tonic seizures eventually resolved on this treatment regimen, but she continued to have daily absence seizures. And it wasn't until she was 11 years old, actually, that she got genetic testing going and was shown to have a GLUT1 deficiency syndrome due to that pathogenic variant in SLC2A1. So GLUT1 deficiency syndrome, with this variant ends up leading to disruption in the glucose transporter across the blood-brain barrier. So patients aren't able to access glucose as that essential energy source for the brain to function as well. And this can lead to a range of clinical presentations like an epileptic encephalopathy or movement disorders with things like exercise-induced dyskinesias. And so the mainstay of treatment for this syndrome is actually ketogenic diet to provide an alternative energy source. So in our patient's case, she got started on the diet and her seizures have since been well controlled. So in this next segment, Dr. Porter will speak about pediatric epilepsy surgery.
Thanks, Katherine. That was fantastic. Thank you very much. I tried to answer everyone's questions that came up, but I think we should have time at the end. So if you end up not feeling like I answered your question, let me know. I can try. All right. I'm going to talk about pediatric epilepsy surgery, which is an option now for a lot more patients than it used to be when I started as an epileptologist like 25 years ago. So I'll try to give you sort of an overview, but there are a lot of specifics for each patient, so we'll probably not be able to go into the detail. But I'd like to first sort of focus on, why epilepsy surgery. And it's really all about, in epilepsy, a cost-benefit ratio. So is the therapy more helpful than the procedure? And I think that it is for more patients than you might think. And then I'm going to focus on how to talk to families about epilepsy surgery in a way that I think we're not doing a particularly good job of sometimes, and that's why it's not being used as much as I think it should be. And then how do we lower the risk and increase the benefit of epilepsy surgery? And then I'm going to talk about neuromodulation, which is the idea of basically, instead of doing a resection or taking something out, you're actually kind of putting in electricity to kind of counteract the abnormal electricity of a seizure. And then I'm going to just end with some future directions that I think will expand our ability to use epilepsy surgery. So why epilepsy surgery? Well, the first and most important thing is seizure freedom. So we know from many hundreds of studies that seizure freedom is a profoundly important part of epilepsy. If you can make someone seizure free, the quality of life, their ability to go forth and get a job, to get married, their ability to have a normal neuronal development, there's financial benefits, and as a whole, the society benefits as well. And so we know that even a rare seizure, so once a year, if you have a seizure, it does impact all these areas. And so it turns out that epilepsy surgery does offer the best option for many of our patients to be seizure free. And the next study that I'm going to talk about on the next slide was one of the original really studies that started to point out to us, and this is only from 2000, but it was a very important study by Quan and Brody, and there were several papers, but this is just one sort of getting at the concept of, we have a lot of seizure medicines. Dr. Xiong did a great job describing some of those options and how they work. But when you start to look at all comers, so these are actually pediatric and adult patients, and what they did in the study was they just took all their patients in their clinic and they looked at whether they were seizure free. And they used a definition of seizure free for a year. And what you can see, if you took all patients, about 63% were seizure free. And multiple other studies have seen the same thing. However you slice up the patient population, what you find is that about 2/3 of patients can be seizure-free on medications and 1/3 just cannot. And they started to look at things like, well, who was seizure-free and who wasn't? And the first thing they realized was that if you had received an epilepsy drug prior to coming to their practice, you were a little bit less likely to be seizure-free. And then if you were receiving multiple seizure medications, so 2 or more, you had a lower rate of seizure freedom. So if it requires a second medication to make you seizure free, you drop from about 2/3 seizure free to about 20% seizure free. And if you are on 3 meds, you are unlikely to be seizure free. So just adding more medications was not making people seizure free. Next slide. They also looked at a study question of if you had seizures, multiple seizures, before you presented to their clinic, was that making you more likely to not be seizure free? And that was true. So if you presented with a single seizure, it was this 60% seizure free. But if you presented with multiple seizure, prior to the presentation, so as high as greater than 20, you only had a 50-50 chance of being seizure free. So what I'm trying to get at is, the second medication, the third medication trial, that's a sign that you're unlikely to be seizure free. Not impossible, but unlikely. And that if you had an abundance of seizures, then you are more likely to not be seizure-free. So we already have two sort of markers of patients that are less likely to be seizure-free: multiple medications and multiple seizures. Next slide. Okay, so what are the options for treating epilepsy with non-medication? Dr. Xiong did a great job talking about the ketogenic diet. And that is one of the options we have. But when they've looked at studies where they start to take all the papers that are out there, that's called the meta-analysis, and they look at those and they say, if you stay on medicines and keep trying to keep tweaking it, like I'm going to find the right medicine, or you actually undergo epilepsy surgery, what's the difference? And what they found was surgery always had a higher, and I'm talking many-fold higher, success rate of seizure freedom than medications across 258 different studies. And there's something called an odds ratio, which just sort of tells you like the odds that surgery is going to help you more than medicine. And a 6.49 odds ratio is a very high number. So surgery was much more successful than medications by a large degree. The next slide will show you that the type of surgery actually doesn't even matter as much. So these are three kinds of epilepsy surgeries that we do quite a bit of. One is the adult surgery that's often done. It's called the temporal lobectomy, and that's TL in this. More commonly in pediatrics, we do extratemporal lobe epilepsy, that's ETL. And then in some kids that have very severe hemispheric epilepsy, we do a hemispherotomy, that's the middle section. And what you see is that no matter whatever the kind of surgery, the odds ratio of seizure freedom is much higher with surgery than compared to medication. And there are some nuances to it, obviously. Some surgeries, bigger surgeries, hemispherotomies, are more likely to make you seizure-free to a greater extent. But even extratemporal lobe epilepsy is still, you're more likely to be seizure-free with a surgery than if you just keep trying medications. Next slide. So the recommendations from the the International League Against Epilepsy very much suggest that every patient with drug-resistant epilepsy under the age of 70 should be referred once they have failed to anti-seizure medications, meaning that they continue to have seizures. And it's not everyone's going to have a resective surgery option, but up to 40% of them will, but yet only about 1% are referred to an epilepsy center that can do surgery per. So we have this distinct issue where we know there are a lot of patients that will be potentially seizure-free with surgery, but very few are actually getting to the right kind of doctors that can help them think about the surgery options. So I want to talk a little bit about what we know about these barriers and what I think are possible solutions. The biggest issue really has been finding the right doctor. So if you are followed by a physician that doesn't have much experience with epilepsy surgery or knowledge about it, they are unlikely to be comfortable in advocating for the surgery. So that's been one of the key, I think, barriers. They also, though, have found that in the case of pediatrics, parents often feel that they have received inadequate information to make informed decisions, and that they're not taking part in the medical decision-making, which is a huge problem for something as complicated as epilepsy surgery. There are also things like insurance obstacles, difficulty navigating that pipeline to get the patients into the epilepsy surgery arena. And then I think that one thing that is really problematic is the delay. So it's a slow process. It's not like I can just look at you and be like, oh, you're a great surgery candidate. You need sort of these additional pieces of information to really decide if you're a surgery candidate and what kind of surgery, and that's a slow process. So some of the things that have been tried are to really overcome these referral barriers. So instead of just saying, oh, you failed 8 or 9 medicines, I'm out of ideas, go see an epilepsy, tertiary care epilepsy center. Don't wait for that. Refer early to discuss at least the options of surgery, but you could also just refer for an epilepsy evaluation. There are centers now that are using automated chart assessments to identify patients that should be referred, and I think that will become more common. Improving communication between the physicians and the families about the risk, utility, and long-term outcomes of epilepsy surgery, I think is probably key. But how to do that in a way that really conveys the risk benefit, I think, is still quite challenging, and a lot needs to be done to really improve this. Next slide. One of the studies, or a couple of studies I've done over the years, have asked this question about what is the perception of the caregiver to make them decide to do epilepsy surgery or not to do epilepsy surgery. And the biggest thing really is the trust and the information they're being provided about the epilepsy surgery process. So if you have a tight bond with your epileptologist and you feel comfortable in their ability to convey to you the information, that is a big bonus. And that is why many parents do decide to do epilepsy surgery, is when they trust the physicians involved. The epilepsy surgery assessment is long, stressful, and anxiety-provoking for parents. And they mention multiple times, I've heard multiple speakers talk about this lack of emotional support. And I think that's very true. It does need to be something that we take into account better than I think we've been able to. And it's very medically complex. It's hard to understand, especially if you have different opinions. Like, I see some second opinion patients, and I might have a different plan than someone else. Well, that really can throw you into a loop. Like, if all the physicians are disagreeing amongst themselves, what does it mean? And I think that's really a challenge for families to deal with, this complexity of it, and not everyone having the same opinion. There have been some studies looking at internet and social media support, and for the most part, it was found to be helpful, but there have been a few cases where I think it's actually been noted that it's more harmful because the information is not accurate. There are support networks with medical knowledge. The Epilepsy Surgery Alliance, I think, is a wonderful organization that really focuses from a caregiver perspective on how to support families in the process. I personally use the Tuberous Sclerosis Alliance a great deal. That's a family focused organization that has a lot of information for patients with tuberous sclerosis. And then we're very lucky at Stanford in that our parent mentor program in the epilepsy neurology world has some experience with that and can be a helpful resource as well. But we need to do better. Okay, next slide. So this is my personal approach. I don't know that it's the right approach, but it's what I've sort of come to over time. So I introduced the concept of epilepsy surgery very early with my patients when they have failed 2 medications. Or if I know that there's a very high likelihood of poor response to anti-seizure medications. It's not that I say your child needs epilepsy surgery. What I say is that we're getting to a point where I'm a little bit concerned medications may not be sufficient, and we need to talk about this process of epilepsy surgery. And I ask them a lot of questions about what they're thinking or feeling or worrying about, so that I kind of have some sense of what their concerns are and what their goals are. At least it's a way to have a shared decision-making platform to work from. Then I tell them about what the process is. So what are the steps? And you don't have to do the whole evaluation at one time, but if you start early and you plan ahead, then you can start to get some of the non-invasive studies done, so that when the time comes that you really have failed several medicines, you're sort of have a good sense of what kind of surgery options there are. We do this at Stanford Children's, where we have shared visits between the neurologists, the epilepsy surgeons, and the families. And that has been, I think, very important so that everybody is talking the same language and on the same page. And then I try to provide external support to other to parents. So you bring in parents that have knowledge and shared experiences, so that they can feel supported. And, I think sometimes people are intimidated from asking questions that they think are too simple or naive, but they're more comfortable discussing those with other families. If you have a question, somebody else probably has the same one. So what does an evaluation entail? It really listening to the history, ask the caregiver to provide videos, use the video EEG. We haven't talked too much about magnetoencephalography, but that's another way to kind of ask the question of where the seizures are coming from. And all of these things are really to just identify the seizure type and the location of the seizures. We already talked a great deal about MRI and genetic testing. I will bring in another form of imaging, which is a PET scan, and explain that to you a little bit. So this is a magnetoencephalography. It's instead of using electrical signals, you're using magnetic signals. And the magnetic signals have some benefit in that the skull and the skin and the fat and all those things don't impact magnetic signals as much as they impact electrographic signals. So a mag basically allows you to identify a seizure focus. In this patient, what you see is each one of these little triangles is a magnetic dipole that was identified in this patient's brain. They're all very nicely clustered around this area. Since I took this from one of my patients, I highly suspect this patient has tuberous sclerosis, and there's a tuber there. So we can use that to really identify which tuber is abnormal. Next slide. The other tool that was mentioned previously, but has really, I think, expanded the number of patients that can have epilepsy surgery with success, is something called the stereo EEG. And it basically uses the information from the video EEG, the routine EEGs, the magnetoencephalogram, the MRI, the PET scan, and it can target the regions of the brain with an electrode into that area. Next slide. So this is a video showing, oh, there it goes. Okay, showing a patient that has electrodes. And what you can see is that you can sample very wide areas. So maybe stop in the middle, Katherine, when you get a chance. Okay, so this patient, I assume, also probably has tuberous sclerosis, since this is my patient. But what you can see is that each one of these little white dots is an electrode, and it's picking up a signal. And you can place these quite broadly in one procedure. You can pick up electrical activity from multiple areas, and you're right in the tissue. So you know which tuber, in this case, probably is causing the seizures. This was really very exciting. This happened in my career. And, I think that it's been probably the biggest impact on the success of epilepsy surgery. The patients actually do quite well because the holes that are drilled are very tiny. There's not a lot of pain associated with it. Next slide. This is the data we obtained from a typical stereo EEG. And what you can see is that instead of 16 contacts, this patient maybe has 120 contacts. And what you can see is the seizure onsets are in these two green areas. Oops. Okay. All right, keep going. We need to get to the Q&A. So I'm going to skip over some of this, but these are all procedures that we do in an epilepsy surgery evaluation. And I would like to just point out that this is a lot of things to do. There are a lot of different people, a lot of technology, and I think this is really something that we do widely in the US and other sort of medically advanced, we'll put it that way. But there are patients that need surgery in multiple other countries that don't have all of this, and they do still have epilepsy surgery. So it's not that every single one of these things needs to be done for you to have a successful epilepsy surgery outcome, but it's worth talking to your epileptologist about which ones are helpful to you and your child if you need it. This is a picture of a PET scan just showing that the energy metabolism is different in areas where seizures come from. The arrow is pointing out a lighter area where the seizures came from. Next slide. There are something called a SPECT scan, which again uses the difference when you're having a seizure with the energy and the amount of blood flow going to an area. Next slide. These are some fancier things even still. We do transmagnetic stimulation, and we do functional MRI to understand where language, memory, motor, sensory, auditory, visual. And this is getting back to that whole concept of the cost-benefit ratio. So if I can say to you, your language is not there, your motor cortex is not there where the seizures are coming from, you do not have visual cortex there, I can safely say to you, you can resect the area where the seizures are coming from and won't impact these areas. So I think that's really important to try to give the cost-benefit ratio as clearly as you possibly can. Next slide. Neuropsych testing, I'll skip over this, but that just is testing that allows us to know where the strengths and weaknesses are in any one patient, and also advise families on how they're doing from a neurocognitive standpoint. Next slide. So we're able to plan a surgery. We have all the information we know where the seizures are coming from, we know the risks of deficits, we know the likelihood of seizure freedom, and we're going to make a decision with this family. So next slide. So this is a patient of mine. She's 2 years old with tuberous sclerosis. She developed focal seizures at 7 months of age. And she currently is on 3 medications for her seizures, very typical ones I use in kids with tuberous sclerosis. But she continues to have some rare seizures. She has this sort of a funny smile and a bit wobbly. The biggest issue has really been, though, her language development is very poor. At the age of 2 years, you should have 50 words, and she does not have 50 words. So is she a surgical candidate? Yes, she is a surgical candidate. We know that her seizures are coming from the left. We know that there are some tubers in the left frontal lobe, and a stereo EEG was performed, and we were able to identify the 2 tubers that the seizures were coming from. It wasn't 1 tuber, it was 2. But they were relatively close to each other. Is there an urgency to doing surgery? Well, my biggest concern is that she is 2 years old and she has only 2 words of language. That is concerning. Questions that we should answer are, is she likely to be seizure-free? Would seizure medications remain? I tried to do all those questions and shared decision-making with the family, and they were very interested in doing epilepsy surgery because they had talked with other families as well. Next slide. This patient underwent a laser ablation. So laser is a way to do epilepsy surgery where you heat a certain part of the cortex up. You don't have to drill a big hole. You can target a very narrow area. The patient underwent the laser. It was about a 5-hour procedure in the operating room. Home 24 hours later, and now she's 8 years old, seizure-free and off seizure medications. And the most important thing was within the first month of the surgery, she had about a 50-word gain in her language, suggesting that the epilepsy was slowing her language development. So next slide. I will say that we're still learning which patients benefit most from laser versus the classic open. We know that there's about a 10 to 20% lower seizure-free rate with laser than open. So if you take large numbers of patients, about 62% are seizure-free with open surgery and only 40% for laser. This is pediatric data, I should say. Lasers are great though, because you spend very little time in the hospital. We know that the pain medication usage is lower and there's a very fast recovery. So it is a tricky thing to figure out which patients benefit from which procedure most. Next. I'm going to just briefly go over neurostimulation really fast since we're almost out of time. Neurostimulation is the idea of fighting electrical seizures with electricity. And there's three main devices: the vagal nerve stimulator, which has been around for a very long time, the responsive neurostimulator, which is a focused area where it recognizes seizures and then sends in electricity, and then deep brain stimulation, which is a way to fight generalized seizures. Next slide. This is a picture of the vagal nerve stimulator. You can find all of these online because companies sell these devices and they have very nice websites for caregivers to sort of explain it. Short procedure, 50 to 7% reduction in seizures after 6 to 12 months, and works on all seizure types. Next slide. Responsive neurostimulation is much more invasive. The electrical signal actually needs to be put where you think the seizures are coming from. It identifies the seizure and then sends an electrical signal to counteract it. Also has good data on, next slide, sorry, good data on seizure outcomes. Final is the deep brain stimulation, next slide, where the electricity is actually placed into nuclei, which are in the deeper parts of the brain, control larger parts of the brain by this method, and has been very helpful in a disorder called Lennox-Gastaut syndrome. I think we're still learning a little bit about neuromodulation. Next slide. But the big take homes are: we need to improve utilization. We need to figure out which timing of surgeries are most important. We need to know the placement of the stimulation, the parameters for the stimulation. And we do have some external neurostimulation devices that are coming along, including transmagnetic stimulation and DC current stimulation. And we're going to hopefully put ourselves out of a job. We're going to have machine learning, read EEGs, SEGs, and MEG, and do much more efficient and effective epilepsy surgery planning so that we can get the success rates higher. I think this is still in its infancy, but it's coming. And I'm looking forward to seeing how we can utilize machine learning to really improve our outcomes. Okay. Holly has posted I just want to thank our families and our patients and the whole epilepsy team, because it is really a sport. It requires a lot of people as a team to really get patients the care that they need.
I think we have a few minutes, Dr. Porter. So for
Okay.
questions, there were a couple in the QA that I figured would be good to save for a broader discussion. So one question that was asked is if there's similar data on efficacy of repeat epilepsy surgery. So like in the example of some of your patients with TS, who may require multiple resections, is there sort of diminishing return for seizure freedom if repetitive resections are required or repetitive surgical
Right.
interventions are required?
Yes, it is known that the success rate for the first surgery, I'm not talking just TS, I'm talking in general, but the first surgery success is probably, it could be as high as 95% if you have temporal lobe epilepsy, but it depends on the type of epilepsy. But the seizure-free rate does diminish if you're requiring multiple surgeries. It never goes to zero because I think most of the time it's more in the 20 to 40% range if you have to repeat the procedure. So I'm guessing it's the complexity of the epilepsy, which we're not able to really encompass in the first procedure. Yeah.
Yep. And then I guess similarly, when you approach sort of surgical interventions for patients now with the new advent of, laser ablation, do you find that you're moving towards a process of like laser first and then bigger surgery for some patients?
Um, so right now we have data on enough patients that I have been utilizing some research questions. One of the research questions is, well, why do some patients do better with laser than others? Why do some have to do open resection? And it's a simple, at least it appears with some preliminary data we have from our center, that it depends on the size and the location of the epileptic onset zone. For some reason, the heat sink is prominent if you're right along the skull surface. And we're trying to work with the companies that make the lasers to improve that so that we could do more laser on patients with very large surface lesions. Yeah. So I think it's coming along. Yeah, we just don't understand. I still do a lot of open cases for a variety of reasons, mostly because the size and the ability in the OR to actually walk your way through the lesions is better. Yeah.
And then I think another interesting question was, do you anticipate advancements in modalities like HD EEG could potentially obviate or remove the need for stereotactic EEG in some cases?
Yes, and I think we are definitely using other modalities to try to avoid stereo EEG, though I think you know things, I'm not sure HD, yeah, to some extent HD EEG, to some extent MEG, source localization, things like that we can use to really use as many tools that are non-invasive as possible, are coming along. I don't know that they're there for every patient.
Totally. And I think concurrently too, as some of our sort of modalities to better identify areas of like eloquence with, fMRI can similarly help with potentially decreasing the need for SEEG too, because that's
Yeah,
another reason why sometimes we use the stereotactic EEGs is for functional mapping.
right.
Um,
I think it's all coming along. Yeah.
yep. Um, okay. Another question was if we have any experience with um, high frequency like ablation with ultrasound in our
We have
population.
not done that on the pediatric side. I know that there are multiple adult centers around the country that are using a focused ultrasound to try and eliminate the need to actually go through the skull, for instance. There have been some side effects and some unfortunate side effects too. So I think it's still an open question of how to use that best. Good questions. The audience
Yeah,
is in the know.
great. Let's see. Another one was I guess now there are a bit more specific ones, like experience with generic versus patented CBD and control of epilepsy. You don't
Hmm.
know what that means, whether it's like CBD, like the prescribed version of Epidiolex versus maybe ones that families get from dispensaries.
Hmm.
Um,
Yeah, I've
or
moved away from that now that it
yeah,
can be so much better controlled.
exactly. I think the challenge with CBD products that come from non-FDA approved sources is that there's just no regulation or ability to know exactly what the patients are getting with concentrations and amounts. And so our counseling to families is typically that like if particularly if they're eligible for the prescription versions, that's always going to be preferred because, we can accurately say that they're getting what they're getting. And we know that CBD in particular can have a lot of side effects with many other anti-seizure medicines that our patients are on. And so that's one of the other sort of challenges and consequences of more generic and non-prescribed iterations of it is that the pharmacokinetic effects on other meds can be really dynamic too.
Mhm.
Yeah.
Yeah, lots of good questions. Thank you all.
Yeah.